In the intricate landscape of geriatric cardiovascular health, the management of hypertension stands as the single most critical challenge, a silent pathology that necessitates a rigorous and often lifelong pharmacological intervention. Yet the modern approach to blood pressure management is frequently complicated by the patient's desire to integrate natural remedies into their therapeutic regimen. Among these natural adjuncts, allium sativum, commonly known as garlic, occupies a revered position in ethnomedicine, celebrated for centuries for its pleiotropic effects on the cardiovascular system, ranging from fibrinolysis to vasodilation. However, a profound misunderstanding of the biochemical interactions between the active constituents of garlic and the pharmacodynamics of synthetic antihypertensive medications has led to a pervasive and dangerous clinical error, one that does not merely result in a lack of benefit, but actively undermines the efficacy of prescribed treatments. This discussion aims to dissect the molecular mechanisms behind this phenomenon, beginning with a rigorous examination of the bioactive profile of garlic and the physiological context of the aging cardiovascular system, to understand precisely why the most common methods of garlic consumption are scientifically flawed and how they set the stage for a deleterious interaction with blood pressure regulation. To comprehend the magnitude of the mistake made by millions of elderly patients, we must first establish the physiological baseline of the aging vasculature, as the efficacy of any intervention, whether synthetic or natural, is dictated by the biological terrain upon which it acts. Aging is characterized by a progressive stiffening of the large elastic arteries, a phenomenon driven by the fragmentation of elastin fibers and the accumulation of collagen within the arterial wall, leading to a condition known as arteriosclerosis, which fundamentally alters the hemodynamics of blood flow. This structural rigidity increases pulse wave velocity, causing the reflected pressure wave to return to the heart during systole rather than diastole, thereby disproportionately elevating systolic blood pressure while lowering diastolic pressure, a hallmark of isolated systolic hypertension in the elderly. Consequently, the therapeutic window for treating hypertension in this demographic is exceedingly narrow. The goal is to reduce systolic pressure to prevent stroke and myocardial infarction without compromising diastolic pressure to the point where coronary perfusion is impaired. Into this delicate hemodynamic balance enters the antihypertensive regimen, typically comprising classes of drugs such as angiotensin-converting enzyme, AC, inhibitors, angiotensin II receptor blockers, ERBs, calcium channel blockers, CCBs, and thiazide diuretics, each meticulously calibrated to manipulate specific pathways of fluid balance and vascular tone. The fundamental error arises when patients introduce garlic into this tightly controlled system under the false assumption that garlic is merely a benign foodstuff or a mild, complementary booster, failing to recognize that garlic, when processed by the human body, functions as a potent pharmacological agent with a mechanism of action that can directly compete with or metabolically accelerate the elimination of these life-saving medications. The complexity lies in the chemistry of the garlic bulb itself, which is not a single active compound, but a chemical laboratory waiting to be activated. The primary precursor found in intact garlic cloves is a sulfoxide amino acid known as alliin, acetylcysteine sulfoxide, which is pharmacologically inert in its dormant state. For garlic to exert any effect on the cardiovascular system, and consequently for it to interact with blood pressure medication, alliin must be converted into allicin, dialylthiosulfonate, the volatile, sulfur-containing compound responsible for garlic's characteristic pungency and its biological activity. This conversion is catalyzed by an enzyme called alliinase, which is sequestered in separate compartments within the plant cells. It is only when the clove is mechanically damaged, crushed, chopped, or masticated that the cell walls rupture, bringing alliin and alliinase into contact to trigger the rapid enzymatic synthesis of allicin. Herein lies the first tier of the great mistake regarding efficacy: the widespread practice of cooking garlic immediately after crushing it, or worse, cooking whole cloves without crushing them, and subsequently consuming them alongside blood pressure medication with the expectation of a synergistic effect. Alliinase is an exceptionally heat-labile enzyme, susceptible to irreversible denaturation at temperatures exceeding 60 degrees Celsius, 140 degrees Fahrenheit. Thus, when garlic is thrown directly into a hot pan, boiled in a soup, or microwaved immediately after preparation, the enzymatic machinery is destroyed before the conversion of alliin to allicin can occur. From a pharmacological perspective, the patient is consuming a placebo with garlic flavor, effectively nullifying the potential vasodilatory benefits that might otherwise support their blood pressure goals. However, the narrative takes a more concerning turn when we consider the scenario where the garlic is prepared correctly, crushed, and allowed to stand to maximize allicin production, or taken as a standardized high-potency supplement, as this is where the biochemical pathways of the garlic constituents begin to intersect dangerously with the pharmacokinetics of antihypertensive drugs. When active allicin is ingested, it undergoes rapid metabolism in the liver and blood, decomposing into various organosulfur compounds such as diallyl disulfide, DADS, diallyl trisulfide, DTS, and agene, which are systemically distributed and interact with the vascular endothelium. The primary mechanism by which these compounds influence blood pressure is through the modulation of nitric oxide, NO, synthase, the enzyme responsible for producing nitric oxide, a potent signaling molecule that induces the relaxation of vascular smooth muscle cells. Under normal physiological conditions, this vasodilation is beneficial. However, in a patient already stabilized on medication, this introduces an uncontrolled variable. The specific mistake regarding the reduction of medication efficacy is often misinterpreted by the lay public as the garlic neutralizing the drug directly in the stomach. But the reality is far more sophisticated and involves the hepatic cytochrome P450 enzyme system. This superfamily of enzymes, particularly the CYP3A4 isozyme, is responsible for the metabolism and clearance of a vast array of pharmaceuticals, including widely used calcium channel blockers like nifedipine, amlodipine, and verapamil. Emerging pharmacokinetic data suggests that certain sulfur compounds in garlic can act as inducers of specific cytochrome P450 enzymes when consumed in large, sustained quantities, which essentially prompts the liver to ramp up its detoxification machinery. When a patient who is stabilized on a specific dose of a calcium channel blocker begins a regimen of high-dose garlic extract or heavy dietary consumption, the induction of these metabolic enzymes can accelerate the breakdown of the medication, shortening its half-life and effectively reducing the serum concentration of the drug below the therapeutic threshold. This phenomenon creates a clinical picture of pseudo-resistance, where the patient's blood pressure begins to creep up despite adherence to their prescription, leading to the erroneous conclusion that the medication has stopped working. This is the crux of the mistake. The belief that natural supplements act independently of metabolic pathways, when in reality, they are fighting for the same enzymatic resources in the liver, potentially stripping the blood of the synthetic agents required to keep arterial pressure within safe limits. Furthermore, the interaction extends beyond hepatic metabolism to the level of the P-glycoprotein efflux pump, a membrane transporter that plays a crucial role in the absorption of drug from the intestinal lumen into the bloodstream. There is evidence to suggest that constituents of garlic can modulate the activity of P-glycoprotein, potentially altering the bioavailability of antihypertensive agents, such as beta blockers and certain ACE inhibitors. If the activity of these transporters is enhanced, the drug may be pumped back into the gut lumen before it can be absorbed, leading to subtherapeutic levels in the systemic circulation. Conversely, if the transporter is inhibited, toxic levels of the drug could accumulate. This variability is the enemy of geriatric medicine, where the physiological reserve is diminished and homeostatic mechanisms are less able to buffer against wide swings in drug concentration. Therefore, the mistake is not merely the consumption of garlic, but the unmonitored, inconsistent, and biochemically naive integration of a potent bioactive substance into a calibrated pharmacological regimen, creating a state of metabolic chaos that renders the precisely calculated doses of prescribed medications unreliable. This biochemical incompatibility is further compounded by the impact of garlic on the angiotensin-converting enzyme, AC, itself. Research has demonstrated that garlic-derived peptides can possess mild ACE inhibitory activity, mimicking the mechanism of action of drugs like lisinopril or enalapril. While one might assume this would be additive and beneficial in the context of reducing efficacy, we must consider the body's compensatory feedback loops. The human body strives for homeostasis when it detects a sudden, aggressive blockade of the angiotensin pathway from two different sources, the drug and the high-dose garlic. The renal system may respond by upregulating the production of renin or altering receptor sensitivity in an attempt to restore pressure, leading to a volatile blood pressure profile that oscillates unpredictably. This unpredictability effectively reduces the clinical efficacy of the treatment plan, as the physician can no longer rely on the predictable pharmacodynamics of the prescribed ACE inhibitor, leading to unnecessary dosage adjustments, the addition of further medications, and a cascade of polypharmacy that could have been avoided. Moreover, the timeline of consumption plays a pivotal role in this interaction, a detail often overlooked in general health advice. The half-life of allicin-derived compounds is relatively short, yet their biological effects on enzyme induction can be sustained. Patients often make the mistake of consuming garlic preparations sporadically or at varying times relative to their medication, creating peaks and troughs in both enzyme activity and vasodilation that do not align with the steady-state release mechanisms of modern extended-release antihypertensives. For instance, taking a potent garlic supplement simultaneously with a morning dose of calcium channel blocker may cause a rapid, acute drop in pressure, hypotension, followed by a rebound period where the drug is metabolized too quickly due to enzyme induction, leaving the patient unprotected during the critical early morning hours of the next day when the risk of stroke is statistically highest. This biphasic response, acute potentiation followed by accelerated clearance, is perhaps the most insidious way in which garlic compromises the long-term effectiveness of blood pressure control, transforming a stable therapy into a physiological roller coaster. As we delve deeper into the cellular mechanisms, we must also address the oxidative stress status of the elderly patient. Hypertension is closely linked to oxidative stress and endothelial dysfunction, where the production of reactive oxygen species, ROS, outpaces the body's antioxidant defenses. Garlic is touted for its antioxidant properties, primarily due to its ability to scavenge free radicals and enhance the activity of endogenous antioxidant enzymes like superoxide dismutase and catalase. While this is generally protective, the interaction with drugs that also rely on redox mechanisms for their metabolism or action adds another layer of complexity. Some antihypertensive agents rely on specific cellular oxidation states to bind effectively to their receptors. If the cellular environment is radically altered by high doses of exogenous antioxidants, the binding affinity of these drugs could theoretically be modulated. This is a subtle, less understood area of pharmacodynamics, but in the context of the biggest mistake, it underscores the danger of assuming that altering the body's chemical environment with powerful phytochemicals is without consequence for the efficacy of synthetic molecules designed to work within a specific physiological range. Therefore, the narrative concludes with the realization that the mistake is a fundamental error in viewing the body as a simple vessel where good things, garlic, and good drugs, medication, simply add up. Instead, the body is a complex biochemical reactor. By ignoring the need for enzymatic activation of garlic, patients waste its potential. But by ignoring the enzymatic competition it creates in the liver, they actively sabotage the pharmacokinetics of their life-saving medications. Building upon the biochemical reality that the human liver acts as a competitive arena for metabolic resources, we must now traverse from the hepatic processing centers to the systemic circulation where the actual hemodynamic battle takes place. For it is here that the mistake of improper garlic integration transforms from metabolic theory into a tangible clinical hazard. The unsuspecting patient, believing they are fortifying their defenses against hypertension, often unwittingly engineers a state of physiological confusion within their own vasculature, a phenomenon that is particularly detrimental when we consider the specific mechanisms of action of the major antihypertensive drug classes, most notably beta-adrenergic blocking agents, or beta blockers, and the widely prescribed diuretics. The interaction here is not always one of direct chemical neutralization, but rather a more insidious form of physiological antagonism and unpredictable synergy that renders the carefully titrated effects of these medications unstable, effectively nullifying the protection they're designed to provide against cardiovascular events. Consider the case of beta blockers, such as atenolol, metoprolol, or bisoprolol, which function by competitively blocking the beta-1 adrenergic receptors on the heart tissue. The primary therapeutic goal of these agents is to reduce the heart rate and the force of myocardial contraction, thereby lowering cardiac output and, subsequently, arterial pressure. They're the brakes applied to a racing engine, ensuring that the heart does not overexert itself in the face of increased vascular resistance. The great mistake occurs when patients consume high concentrations of active garlic compounds, specifically the polysulfides generated from fresh, crushed cloves, which possess a potent, dose-dependent vasodilatory effect mediated by the opening of potassium channels in the vascular smooth muscle cells and the stimulation of nitric oxide production. While vasodilation sounds inherently beneficial for a hypertensive patient, the timing and intensity of this garlic-induced vessel widening can trigger a compensatory reflex known as baroreceptor reflex tachycardia. When the blood vessels dilate suddenly due to a surge of garlic-derived polysulfides, the systemic blood pressure drops acutely. The baroreceptors in the carotid sinus and aortic arch detect this rapid fall and signal the autonomic nervous system to restore pressure by increasing the heart rate. Here arises the pharmacological collision. The beta blocker is trying to slow the heart down to control pressure, while the body's reflex response to the garlic's sudden vasodilation is screaming for the heart to speed up to maintain perfusion to vital organs. This creates a tug-of-war on the myocardial tissue, where the drug's efficacy is functionally blunted by the body's own desperate attempt to counteract the variable hemodynamic shifts caused by the supplement. The clinical result is often a patient who presents with erratic heart rates and fluctuating blood pressure readings, leading the physician to believe that the beta blocker dosage is insufficient. Consequently, the dose might be increased unnecessarily, pushing the patient toward bradycardia, dangerously slow heart rate, during the periods when the garlic effect wears off, simply because the natural remedy introduced a variable of instability that masked the true therapeutic baseline of the medication. The mistake, therefore, is failing to realize that lowering blood pressure is not a singular, uniform action. It is a complex orchestration of cardiac output and peripheral resistance, and by crudely manipulating resistance with garlic while the drug is manipulating output, the patient disrupts the harmony required for safe management. The narrative of conflict extends further into the domain of diuretic therapy, particularly with thiazide diuretics like hydrochlorothiazide and loop diuretics like furosemide, which remain cornerstones of geriatric hypertension treatment. These medications operate on the delicate filtration units of the kidney, the nephrons, to inhibit the reabsorption of sodium and chloride, thereby enforcing the excretion of water to reduce blood volume and pressure. Garlic, in its raw and potent form, also exhibits distinct natriuretic, sodium-excreting, and diuretic properties, likely due to the action of its sulfur components on renal blood flow and filtration rates. When a patient combines a prescribed diuretic with a high-intake garlic regimen, they risk precipitating a state of additive volume depletion that goes beyond the therapeutic intent. This does not merely lower blood pressure. It can aggressively strip the body of essential fluids and electrolytes, leading to dehydration and, critically, hyponatremia, low sodium levels, or hypokalemia, low potassium levels, depending on the specific diuretic used. In the elderly, whose homeostatic reserve for correcting electrolyte imbalances is significantly diminished due to age-related decline in renal function, this interaction is perilous. The reduced efficacy in this context is paradoxical. The medication works too well in terms of fluid removal, but fails in its primary goal of safe stabilization. The resulting electrolyte disturbances can cause muscle cramps, arrhythmias, and profound weakness, often mimicking the symptoms of heart failure or drug toxicity. When a patient reports these symptoms, the typical medical response is to lower the dose of the diuretic or discontinue it, under the false assumption that the patient is intolerant to the drug. In reality, the drug was perfectly tolerated until the unmonitored diuretic effect of the garlic pushed the physiology over the precipice. Thus, the garlic use leads to the withdrawal of a necessary medication, leaving the patient ultimately unprotected and vulnerable to the rebound hypertension that follows the cessation of therapy. Furthermore, we must address the specific interaction with the renin-angiotensin-aldosterone system, RAS, the hormonal cascade targeted by ACE inhibitors, like lisinopril, and ARBs, like losartan. As touched upon previously, garlic has shown potential to inhibit ACE activity naturally. However, the mistake lies in the assumption that this natural inhibition is consistent or reliable enough to complement synthetic inhibitors. The chemical complexity of garlic means its ACE-inhibiting peptides are variable in concentration, depending on the soil the garlic was grown in, the harvest time, and the preparation method. When a patient relies on this inconsistent natural inhibition alongside a precise synthetic inhibitor, they introduce a pulsatile effect to the therapy. On days where garlic consumption is high or the bulb is particularly potent, the combined suppression of angiotensin II can cause acute hypotension, a sudden, dangerous drop in pressure that can lead to syncope, fainting. This is especially critical in the geriatric population, where arterial stiffening has already compromised the ability of the blood vessels to constrict rapidly upon standing. This brings us to one of the most severe consequences of this drug-nutrient interaction, orthostatic hypotension. This condition, defined by a significant drop in blood pressure upon standing, is a leading cause of falls and hip fractures in the elderly, events that are often terminal or life-altering. Antihypertensive medications are carefully titrated to lower sitting blood pressure without causing the standing pressure to bottom out. However, garlic's mechanism of action includes the relaxation of smooth muscle tone in the peripheral veins, which increases venous capacitance, pooling of blood in the legs. When an elderly patient taking a vasodilator drug, like a calcium channel blocker or an alpha blocker, consumes a remedy that further relaxes venous tone, the return of blood to the heart upon standing is critically compromised. The brain is momentarily deprived of oxygen, leading to dizziness or a fall. In the aftermath of such an event, the blame is almost invariably placed on the medication, leading to its discontinuation or dosage reduction to subtherapeutic levels. Moreover, the interaction is not limited to hemodynamics, but extends to the very blood that flows through the vessels. While not a direct blood pressure medication interaction in the strict sense, the concurrent use of garlic with antiplatelet agents like aspirin or clopidogrel or anticoagulants like warfarin is a critical component of the cardiovascular management profile for many hypertensive patients who also have atrial fibrillation or a history of ischemic events. Garlic contains a gene and other compounds that inhibit platelet aggregation and fibrinogen binding, effectively thinning the blood. While this is a touted benefit of garlic, in a patient already anticoagulated to a precise international normalized ratio, INR, the addition of garlic acts as a silent potentiator of bleeding risk. This connects to the reduction of antihypertensive efficacy in a complex behavioral loop. If a patient experiences frequent bruising, gum bleeding, or subconjunctival hemorrhage, red eye, due to the garlic drug synergy, they often become non-compliant with their entire medication regimen, stopping their blood pressure pills out of fear that too much medication is harming them. They wrongly attribute the bleeding solely to the pharmaceuticals, not realizing that the garlic is the catalyst that pushed their hemostatic balance into the danger zone. The complexity of these interactions is further deepened by the issue of bioavailability competition within the gastrointestinal tract. The absorption of many antihypertensive drugs relies on specific pH environments and transporter proteins in the gut lining. Consuming large amounts of raw garlic or concentrated garlic oil supplements can alter the gastric pH and stimulate gastric secretions. for acid-labeled drugs, or those requiring a specific pH for dissolution. This change can retard absorption or degrade the molecule before it enters the systemic circulation. Additionally, the sulfur compounds in garlic can physically interact with mucosal transporters, potentially blocking the uptake of the drug molecule or, conversely, increasing the permeability of the gut wall to allow for dose dumping, where the drug enters the bloodstream too rapidly. This pharmacokinetic variability means that the 10 milligrams of medication the patient swallows does not equate to the predictable plasma concentration the doctor expects. One day, the absorption might be 50% due to garlic interference. The next day, it might be 100%. This oscillation makes it impossible to achieve the steady-state concentration required for effective 24-hour blood pressure control, leaving the patient exposed to hypertensive spikes during the windows of poor absorption. We must also scrutinize the widely propagated myth of the safety of aged garlic extract, AG, compared to raw garlic. While AG is often marketed as odorless and less irritating to the stomach, and indeed contains different bioactive profiles, higher in S-allylcysteine and lower in allicin, it is not metabolically inert. S-allylcysteine is a potent antioxidant and modulator of cellular signaling pathways. Research suggests that even these stabilized forms can interact with the P-glycoprotein transporter system mentioned in Part 1. The mistake patients make is assuming that because the supplement is processed or odorless, it has been stripped of its ability to interact with medications. On the contrary, the concentration of specific phytochemicals in these extracts can be magnitudes higher than in dietary garlic, effectively presenting the liver and kidneys with a pharmacological load that rivals the prescribed medication itself. This creates a scenario of polypharmacy by supplement, where the patient is technically taking 2 or 3 blood pressure agents, 1 synthetic, 1 or 2 botanical, without the medical oversight required to manage such a combination. Finally, in this section, we must acknowledge the psychological component of this mistake, the license to indulge. A subtle but damaging reduction in medication efficacy occurs when patients use garlic as a crutch to justify poor lifestyle choices or non-adherence to dietary restrictions. The belief that the garlic will clean out my arteries or neutralize the salt often leads elderly patients to consume higher sodium diets or skip doses of their medication, thinking the natural remedy provides a safety net. This behavioral interaction is as potent as any biochemical one. The sodium retention caused by dietary indiscretion overwhelms the mild diuretic capacity of the medication, rendering it ineffective. The garlic, in this scenario, becomes an enabler of the very pathology the medication is trying to treat. The physiological reality is that no amount of garlic-induced vasodilation can mechanically overcome the fluid volume overload caused by high sodium intake in a rigid arteriosclerotic vascular system. Having traversed the complex biochemical terrain where the metabolic pathways of allium sativum intersect with the pharmacokinetics of antihypertensive therapy, and having witnessed the physiological discord that arises when these two potent forces collide within the aging cardiovascular system, we arrive at the pivotal juncture of resolution. For the objective of this rigorous analysis is not to demonize a culinary staple that has served humanity for millennia, but to illuminate the path toward a scientifically sound coexistence between natural tradition and modern medicine. The mistake we have dissected is not the consumption of garlic per se, but the chaotic, uncalibrated, and chemically naive manner in which it is introduced into a system already under strict pharmacological regulation. Therefore, the correction of this error requires the adoption of a structured protocol that respects both the potency of the botanical and the precision of the pharmaceutical. The solution lies in the application of chronopharmacology, the science of timing medication and nutrient intake, and a disciplined approach to dosage consistency that allows the physician to titrate the prescription against a stable background of dietary intake rather than a fluctuating variable of herbal interference. The first and most critical pillar of this corrective strategy is the establishment of a safe therapeutic window regarding the timing of consumption, a concept often neglected in general nutritional advice, but paramount in geriatric pharmacology. Given that the competitive inhibition and induction of hepatic cytochrome P450 enzymes by garlic-derived organosulfur compounds can alter drug metabolism for several hours post-ingestion, it is chemically imprudent to consume potent garlic preparations simultaneously with blood pressure medication. The common practice of swallowing a pill with a glass of water immediately followed by a meal rich in raw garlic, or worse, washing down a garlic supplement with a morning medication, maximizes the potential for absorption conflict and transport modulation in the gastrointestinal tract. To mitigate this, a temporal separation of at least 2 to 4 hours should be strictly enforced between the administration of the antihypertensive agent and the consumption of therapeutic doses of garlic. This allows the drug to be absorbed, undergo first-pass metabolism, and reach peak plasma concentrations without immediate interference from the bioactive surge of allicin and its derivatives. By staggering these inputs, the patient reduces the risk of the acute additive hypotension and the bioavailability competition at the level of the P-glycoprotein transporters, ensuring that the drug has secured its therapeutic foothold before the system is challenged by the botanical modulator. However, timing alone is insufficient without addressing the volatility of dosage, which brings us to the principle of dietary consistency versus episodic loading. The human body, particularly in the later stages of life, craves homeostasis and thrives on predictability. The liver's enzymatic profile adapts to chronic exposure but struggles with acute spikes. The mistake many patients make is the episodic loading of garlic. Consuming huge quantities for a few weeks to clean the blood, and then stopping or eating it sporadically in large amounts. This creates a sawtooth pattern of enzyme induction where the clearance rate of the blood pressure medication accelerates and decelerates unpredictably, making it impossible for the physician to find the correct dosage. The scientific correction is to maintain a consistent, moderate dietary baseline. If a patient chooses to consume garlic, they should do so in uniform culinary amounts daily, rather than oscillating between abstinence and high-dose supplementation. When the intake is consistent, the hepatic enzyme levels stabilize a new baseline, allowing the physician to adjust the medication dosage once to account for this steady state, effectively calibrating the prescription to work with the patient's diet rather than fighting against a moving target. This leads us to the crucial distinction between culinary integration and high-potency supplementation, a boundary that is often blurred by the supplement industry. The concentration of bioactive sulfur compounds in aged garlic extracts, garlic oils, and pulverized garlic pills can exceed that of dietary garlic by orders of magnitude, effectively crossing the threshold from food to drug. For an elderly patient struggling with blood pressure control, the biggest mistake is often the unauthorized addition of these concentrated supplements without medical oversight. The rigorous recommendation for this demographic is to prioritize the culinary use of whole garlic cloves over processed supplements, as the natural matrix of the plant provides a self-limiting mechanism for dosage. One can only eat so much raw garlic before gastric irritation occurs, whereas supplements allow for the ingestion of massive pharmacological loads that can overwhelm metabolic pathways. Furthermore, utilizing the whole food ensures the presence of the full spectrum of constituents, including the fibers and prebiotics that support the gut microbiome, which is increasingly recognized as a regulator of blood pressure, rather than isolating a single chemical fraction that may have aggressive drug-interacting properties. We must also refine the method of preparation, revisiting the enzymatic mechanics of alliinase discussed in the opening of our analysis, but this time with a focus on safety rather than just potency. For patients who are sensitive to the hypotensive swings caused by raw garlic, or those on complex multi-drug regimens, polypharmacy, where any metabolic variation is risky, the deliberate thermal deactivation of the enzyme may be a strategic choice. While the health enthusiast is told to crush and wait to maximize allicin, the patient with fragile blood pressure control might be better served by cooking the garlic immediately or using it in boiled dishes, thereby degrading the heat-sensitive alliinase and preventing the formation of the most volatile, drug-interacting sulfur compounds. This approach retains the flavor and the stable, less reactive cysteine derivatives like acetylcysteine, which offer antioxidant protection without the aggressive vasodilation and enzymatic induction associated with raw allicin. This nuance, choosing a preparation method that aligns with one's pharmacological vulnerability, is a hallmark of personalized nutritional medicine, moving beyond the binary eat it or don't advice to a sophisticated manipulation of food chemistry for safety. The dialogue between patient and physician acts as the final safeguard in this protocol, yet is often characterized by silence regarding natural remedies. The correction of the great mistake requires a fundamental shift in this communication. The patient must explicitly disclose not just garlic use, but the form and frequency of that use. A physician knowing a patient eats garlic bread occasionally is different from knowing a patient takes 2 grams of garlic extract daily. With full disclosure, the physician can monitor for specific signs of interaction, such as unexplained potassium fluctuations in those on diuretics or paradoxical bradycardia in those on beta blockers. Furthermore, the patient must be educated to recognize the warning signals of a deleterious interaction, the onset of dizziness upon standing, orthostatic hypotension, unusual fatigue, or the emergence of new bruising, which indicate that the delicate balance between the anticoagulant properties of the garlic and the hemodynamic effects of the medication has been breached. Empowering the patient to view these symptoms not as random signs of aging, but as biochemical feedback from their own body, allows for early intervention before a catastrophic fall or stroke occurs. Ultimately, the synthesis of this extensive inquiry leads us to a profound conclusion about the nature of geriatric health management. The belief that natural equals neutral is a dangerous fallacy in the context of modern pharmacology. The garlic bulb is a powerhouse of biological activity, a chemical factory capable of modifying the fundamental parameters of blood flow, clotting, and drug metabolism. Its potential to clash with the sophisticated machinery of antihypertensive drugs is not a defect of the plant, but a testament to its potency. The biggest mistake is not the desire to use garlic to support health, but the failure to respect the biological potency of what is being consumed. It is the error of introducing a chaotic variable into a life-critical equation. By understanding the mechanisms of enzymatic competition in the liver, the additive effects on vascular tone, and the risks of volume depletion and electrolyte imbalance, the elderly patient can transition from a passive consumer of trends to an informed guardian of their own physiology. The path forward is one of informed moderation and chronopharmacological awareness. It involves rejecting the allure of high-dose miracle supplements in favor of consistent culinary enjoyment. It demands the discipline to separate the timing of food and medicine to respect the liver's processing capacity, and it necessitates a transparency with healthcare providers that treats diet as an integral part of the therapeutic prescription. When garlic is stripped of its mythical status and understood through the lens of biochemistry, it ceases to be a hidden saboteur of blood pressure medication and returns to its rightful place as a valuable, flavor-enhancing component of a heart-healthy diet. The efficacy of the life-saving medication is preserved not by banning the garlic, but by managing the relationship between the two with the same precision and respect that we accord to any other aspect of medical science. Thus, the patient secures the best of both worlds, the rigorous protection of pharmaceutical science and the time-honored benefits of nature, coexisting in a state of carefully engineered balance, ensuring that the golden years are navigated with both safety and vitality.